Thank you. And yeah, let's begin. I have no relevant financial relationships. So really the key objective, this article is a true tour de force. I've never seen such a comprehensive overview of cardiac tumors. You can tell it's a labor of love performed at the Mayo Clinic, and one that really 40 minutes or an hour is not enough time for this topic at all. But what I wanted to do was to give a nice broad overview of clinical and multimodality imaging. Of clinical and multimodality imaging characteristics with pathological reviews to improve diagnostic evaluation of the following, both metastatic, the most common, over 60% of cases, and primary cardiac neoplasms, cancer therapy-related cardiotoxicity, and non-malignant systemic disease with cardiac involvement will be touched upon, such as amyloidosis, carcinoid heart. So these are some pretest questions that y'all can mull over before we move on towards the discussion itself. This article focuses both on mechanisms of cardiac involvement in neoplastic disease. This includes routes and metastases. So the first question addresses this: which of the following malignancies most commonly metastasize to the heart via venous extension? Choices being lung adenocarcinoma, melanoma, lymphoma, and the renal cell carcinoma. Question 2 is one that weds the concept of anatomic localization with typical clinical presentation. A lot of these tumors present heterogeneously, so all these questions are most likely. So which of the following most commonly occurs in the right atrium and likely to present clinically? Pericardial effusion and tamponade. Choices being A, fibroma, B, myxoma, C, angiosarcoma, and D, hemangioma. Next question is, now we're starting to get into the real meat of the topic, is how to combine multimodality imaging, clinical characteristics, and anatomic localization into a non-invasive diagnosis of cardiac tumors. So this primary cardiac tumor is most often located in the left atrium, demonstrates low attenuation on CT and T2 hyperintensity on cardiac MRI. Options being A, lipoma, B, fibroma, C, papillary fibroelastoma, D, myxoma. And 4, again, test this similar concept that we hope that y'all can appreciate throughout this presentation, is this primary cardiac tumor usually appears hyperechoic on echocardiography and hypointense on T1 and T2 with homogeneous delayed late gadolinium enhancement on cardiac MRI. Options being A, rhabdomyoma, B, fibroma, C, lipoma, and angiosarcoma. So I hope at the end of this discussion, you'll be able to at least narrow down or get the right answers to these questions. So this is the article itself. This is a collaborative effort by Dr. Malazewski of Department of Pathology and the Department of Cardiology, led by Kyle Klarich at the Mayo Clinic. So the background of this article really stems from the 2015 revision of the WHO classification of cardiac and pericardial tumors. So the advances in the pathobiological knowledge, specifically genetics and molecular and histopathology of these tumors, led to simplification and due to this understanding that the similarities of these cardiac tumors to their non-cardiac counterparts. This led to making the nomenclature much more simple and actually more generalizable to both cardiac and non-cardiac, and also enhanced understanding of syndromes related to primary cardiac neoplasia, which I'll go through examples throughout the presentation. Also, advances in multimodality imaging specifically has improved the non-invasive diagnosis of these cardiac tumors. Usually first-line echocardiography has initial benefits in determining certain characteristics of tumors, such as the calcium. Whether there is a tumor is often the first line test, other than incidental findings on CT, which is often done, which is often the case. Also, foreign bodies and mobility is a key aspect that echo is superior to the other two modalities. Well, the one that has really revolutionized the diagnosis of cardiac tumors is the MRI, and the enhancements in a tumor protocol, mass tumor protocol standardization, and understanding the differences between sequences have been able to differentiate tissue characterization of cardiac tumors, look at extracardiac extension, fat, and vascularity of tumors, as well as even like predict necrosis and other aspects of cardiac tumors. You can very easily differentiate metastatic versus benign primary cardiac neoplasia with MRI, which I'll go into further detail. CT scan have been very beneficial for surgical planning, as well as further differentiation of calcium deposition. It's a superior test for that. Looking at the epicardial coronary arteries, superior test for that. A very good modality as well in combined. MRI and CT have to be electrocardiogram gated. There are issues with arrhythmias as well in evaluating these patients. However, it's continuing to improve and improve. The table next to this slide, first one looks at the different modalities and compares which one's superior. This was also a great systemic review written by Dr. Malazewski in Nature Review Cardiology. The other table is from Dr. Motwani in radiology, and he goes through characteristics which can differentiate malignant tumors, and specifically if they're large size, irregular, direct invasion through tissue planes, and the involvement of the right heart, highly suspicious, pericardial or pleural involvement as well, multiple lesions, in contrast to tissue characteristics, looking at certain differences in weighting, like tissue heterogeneity on T1 and T2 weighted images. So T1 more water specific, T2 you can see both fat and water, and then fat suppression, seeing it stacking imaging, to looking at the size of the mass as well. So these are all different characteristics that the different sequences of cardiac MRI can increase the specificity of detecting a cardiac malignancy to 0.9 area under curve for receiver operating characteristic. So we've made just tremendous advances in non-invasive diagnosis of cardiac tumors. As here is a great table from the article by Motwani that Dr. Malazewski cites in the Nature paper. You can see the differences in different sequences of cardiac MRI can help determine tissue differentiation and tumor differentiation in benign and malignant masses. And that's just due to the tumor characteristics histopathologically, that there's increased vascularity. You would see heterogeneous or increased uptake on the T1 sequence. T2 weighting as well is beneficial because you can do fat suppression and to better differentiate as well. And cine stacking can allow for better assessment of the size of the tumor as well. So all these advances have significantly improved diagnosis. Late gadolinium enhancement, very important for evaluation of cardiac scarring, as well as direct invasion of myocardium. So this is a central illustration of Dr. Malazewski's article looking specifically at direct mechanisms of cardiac involvement. So this is looking both at tumors, primary and metastatic, as well as indirect mechanisms of cancer therapy-related cardiotoxicity and systemic diseases with cardiac involvement. So you see here in the direct mechanisms, they include hematolymphoid metastases, which are often seen in tumors that spread hematogenously. Melanoma and lymphoma are characteristic cancers that spread to the heart this way. Then there's also retrograde lymphatic seeding, like with the breast carcinoma. The intramammary nodes are often area where they spread as well. And direct venous extension, as seen in the particularly thrombogenic renal carcinoma, is another mechanism of spread to the heart. Direct metastases, often you see these in lung cancers. I've seen diffuse large B-cell lymphomas, anything that involves the pericardium or mediastinum having direct metastases to the heart. Primary cardiac tumor growth, I'll go into those in greater detail. They often have specific patterns of anatomic localization and histopathology, as well as embryologic determinants of why they arise from particular structures. There's also intraluminal tumor growth, and that's another aspect of spread through the vessels. Now, looking at indirect mechanisms, they include thoracic radiation therapy, which a lot of landmark work's been done from the children's cancer survivorship cohort, and then subsequent studies examining mean heart dose and risk of radiation-induced cardiac toxicity, which can include even valvulopathies, increased calcification in the valves, arrhythmias, all sorts of diseases, intrusive pericarditis, etc. Then there's also spread of carcinoid tumor. We'll go into a little detail about the spread to the heart from carcinoid syndrome, and plasma cell dyscrasia and the cardiac amyloidosis, which is a hot topic as well. And multiple advances in multimodality imaging have been ongoing in that field as well. So metastatic cancer. So metastatic cancer incidence is approximately between 0.7 to 3.5% in the general population. It is by far the most common cause of cancer in the heart. The incidence of metastatic disease to the heart is 0.7 to 3.5%. Lung, breast, hematologic tumors, and melanoma are the most common malignancies that metastasize to the heart. Clinical presentation is often nonspecific, and often it presents late. So it's often stage 4 when there's heart involvement from a different unknown primary tumor at the time. And clinical presentation really depends on which area is involved and the mode of spread. So pericardial metastases is the most common mode, greater than 60% of cardiac metastasis. And you will see the signs of pericarditis on ECG or clinically significant tamponade. Myocardial metastases, they account for about 1/3 of these cases, and they're more difficult to detect at times. They can be arrhythmias, chest pain, or just nonspecific symptoms. Sometimes they mimic ACS as well. And the least common involvement is endocardial. It's quite rare, 3 to 5% of cases. And in terms of assessment, usually first line is echocardiography. A lot of information can still be gained from that to even determine whether there's an echogenic mass of concern or multiple masses. And once that's performed, if the patient can tolerate cardiac MRI, this is a very useful test in looking at tissue differentiation. CT scan has higher spatial resolution, allows for greater assessment of 3-dimensional volumetric coverage. As mentioned, you can see the epicardial coronary arteries better, and you can do a non-invasive evaluation of calcium there. But it's also pretty helpful for surgical planning as well. And transesophageal echocardiography is also good for looking at direct involvement of the of the cardiac structures by the tumor, as well as intraoperative surgical resections. So some imaging characteristics that I put on this slide that are notable are metastatic melanoma, often known for T1 hyperintensity, and direct pathology is quite obvious. It's the melanoma, just based on the appearance and immunostaining. High cellular tumors, examples include carcinomas that show restricted diffusion. There are more water content in the highly vascular tumors, like the renal cell carcinoma, which we will see highly avid contrast enhancement. So here I have some examples. This is a metastatic renal cell carcinoma, and what you can see here is a patient that has metastatic renal carcinoma of the left ventricle, and then follow-up cardiac MRI 18 months after chemotherapy, showing complete loss of the central enhancement and some increased peripheral enhancement. This is all indicative of a necrosis from this tumor and surrounding inflammation. So switching gears now to primary cardiac neoplasms, a lot of breakthrough advances have been made in identifying genetic drivers and associated syndromes with particular cancers. And these advances have led to, as I mentioned, the simplification of the WHO and revision of the WHO 2015 classification of cardiac tumors. So these genetic markers that have been identified include notable ones: the somatic driver mutations in Myxoma, PRKAR1A, Fibroma, PTCH1, repair gene in DNA is involved with the nevoid basal cell carcinoma syndrome, also known as Gorlin syndrome, which I'll go into greater detail later, as well as you can see other different genetic drivers of these diseases. Some diseases are much more complex. Angiosarcoma, we still have a poor understanding of this highly devastating disease with high one-year mortality rates, but it has a very complex cytogenetics, and we're still trying to develop an understanding of these particular cancers. So moving on to the benign tumors. So Dr. Malazewski, he goes through each tumor very nicely in a multimodality panel, including a gross histopathology echocardiogram and cardiac MRI. So a common tumor that many of y'all have encountered is the papillary fibroelastoma. And these tumors can often occur in the setting of prior cardiac surgery. They're usually smaller mobile lesions. They're second most common, although some data is showing that it's more common than previously thought in the cardiac myxoma. They represent neoplasms, but they tend to be more like reactive findings as well. So that's why they tend to occur in the setting of post cardiac surgeries, and they can present late from cardiac surgery. Majority of patients are asymptomatic. They do not usually develop symptoms unless an event like a systemic embolization or heart failure or arrhythmia leading to sudden cardiac arrest. It's a very heterogeneous presentation, so you really can't just go by clinical presentation. What is usually found on imaging characteristics is what you'll see is this tumor rising from a stalk, a frond-like appearance, and that's been often compared to sea anemone. So as you can see in image A here, this tumor has that appearance echocardiographically. They also have this characteristic speckled appearance, which you can also appreciate in this image. Cardiac MRI will show some T2 hyperintensity related to connective tissue and mucopolysaccharide matrix. CT will allow for actually pretty great characterization of these lesions due to the high spatial resolution. And macroscopically, what you see here is that C enemy appearance, very characteristic in that. And so treatment for these tumors is usually surgical resection. Controversy exists on how to manage them and when the mass is found incidentally. But in cases of embolization, at least in our institution, surgery is often offered to prevent other devastating clinical consequences like strokes, and depending on the mobility or size of the mass. So looking at surgical approaches, it's trying to look into more minimally invasive, using like upper hemisternotomy or right parasternal incision, which I've seen here, and occasionally even robotic cases, which we don't do as often, but are also done here. Myxoma. So this is the most common primary benign cardiac tumor. It's very heterogeneous in clinical presentation again, depending on involvement of anatomy, as well as it can present with arrhythmias, heart failure, systemic embolization. All depends on its localization. They tend to occur in the left atrium. One interesting somatic mutation associated with the myxoma in approximately 5% cases is PRKAR1A, and this can lead to the so-called Carney complex, which is a syndrome that involves myxomas, endocrinopathies, still have benign skin nevi, and even some non-myxomatous tumors. And this is all related to somatic driver mutations of this particular gene. So cardiac myxoma is it should always be in the differential, and molecular testing is of benefit in these patients. However, in terms of management imaging, usually echocardiography will easily identify a particular pedunculated mass, often attached to the atrial septum, and has a very characteristic appearance on echocardiography. But atypical myxomas, which we've seen at our institutions, they may be more difficult to differentiate from thrombus and or papillary fibroelastoma, which I'll go into a case shortly. And in that scenario, superior tissue characterization with cardiac MRI may be particularly helpful. And here you can see the different images illustrating the myxoma, the pedunculatus mass, and the apical four-chamber view of the echo, as well as prolapsing during diastole. And you can see M mode, the tumor obstructing the mitral orifice, cardiac MRI imaging sequencing, T2 weighted triple inversion showing the right atrial mass, as well as the post-contrast inversion showing a rounded, smooth mass, often smooth and rarely irregular, but they can be also very friable on the gross histopathology. And you see the myxoid stroma here. So this is an interesting case that we encountered here at Methodist Hospital. So this is a woman who presented to our institution with a cardio-embolic stroke and an incidental finding of an echogenic mass, which you can see here. So the patient had an interesting surgical history in that years prior, around over 7 years ago, Dr. Reardon performed a cardiac autotransplantation for a myxomatous tumor involving the mitral valve papillary muscle. However, the patient had a bioprosthetic mitral valve replacement and tumor resection, and initially did well. However, she again presented years down the road with this cardioembolic stroke. And when we saw the echo, we saw this mass that we saw was on the bioprosthetic valve. If you can see here in the surgeon's view of the mitral valve on 3D echo, you see this mass arising from the bioprosthetic valve. We weren't sure if it was an underlying recurrence of myxoma from the papillary muscles, or whether it was separate tumor like a papillary fibroelastoma in the setting a delayed onset from surgery. Our other differentials, of course, were thrombus. We did a full systemic eval of cancer, screening, history, scander as well. And what we saw is, again, this mass in between the LV and the LA right here, as well as we ended up at this point deciding that surgical resection would be the route to go because she did not show significant improvement with anticoagulation and serial transesophageal echocardiogram. So at that point, we resected. Dr. Reardon performed this resection and redo MVR on bypass. And what we found was a tumor with fibrin and entrapped histiocytes with C68 positivity on immunostaining, concerning for either a degenerated myxoid tumor or non-bacterial thrombotic endocarditis, unable to differentiate. Clinically, she had no signs of endocarditis, no fevers, chills, and entire infectious workup extensively was negative, as well as a hypercoagulable workup was negative. So it shows you how difficult these masses can be for diagnosis, treatment, and management, and nothing is ever clear-cut. So another anatomic variant you can look at is lipomatous. Yep.
Al, on that previous case that you highlighted,
Yep.
What do you think, or what was the sort of final assessment of that?
So Dr. Reardon, I spoke to him directly, and he thinks it was sarcoma all along. The way this tumor behaved was hardly benign. He thinks it was the findings on pathology are likely a degenerated sarcoma, that this tumor was always a sarcoma, just due to anatomic localization, involvement of the papillary muscles. Very atypical for myxoma to involve papillary muscle. Seems like it would be more of a sarcomatous presentation. However, the pathology was so nonspecific and didn't really show any of the typical tumor markers. So.
And what about the previous pathology, the one from the surgery 7 years earlier?
So the auto transplantation, that was clear cut. It was myxomatous, but it had the way it was myxomatous, but it was more clear cut than this one. So this tumor was likely heterogeneous. It's very difficult to say because he actually thinks it was a sarcoma from the onset too.
And the original pathology didn't really show sarcoma, but it showed myxoma.
Yeah, it was not a well differentiated myxoma from the onset. Yeah, so it's really difficult to say if this is a degenerative sarcoma that recurred, that was always like that, or was it just some heterogeneous tumor with myxoid elements. It's a very interesting case in that this is the only second case of a tumor on a bioprosthetic valve that we've read. So it was a very interesting presentation.
So I would, you're kind of going through the various figures that were in the paper, and Dr. Malazewski is actually on the call, I believe, and you have a pathology, or he has a pathology slide where it's about cardiac myxoma. Yeah.
Much appreciate your expertise.
My question would be, in that pathology slide on that paper, there's a myxoma, and it has arrows in it, and then it says that the neoplastic cells of the myxoma are necessary for making the diagnosis. And I was just curious if he could answer, kind of what, because the implication is that a myxoma is a benign tumor, but here you're talking about neoplastic cells. So I'm just curious if the case that you're presenting is similar to what he's getting at.
Yeah. So like, yep. Dr.
Oh, okay. Am I unmuted?
Yeah,
You're
please feel
you're
free.
live.
Yeah.
All right, fantastic. Yeah, the photomicrograph that's shown there in the left lower portion of the slide, there's nothing in there that's indicative at all of a myxoma. That is most decidedly not a myxoma. Those are not myxoma cells. In fact, I mean, at this altitude, it's a little hard to further characterize the cell. Do you know what immunoperoxidase study is shown over on the right there?
That's a CD68. So that's why we're
A
thinking non-bacterial thrombotic endocarditis.
Yeah, so I mean, all that means is that there's monocytes in there, and I think you'd really need to fish around and look in the rest of this. Obviously, most of this back here isn't myxoid stroma. Most of that's fibrin, and obviously all of those are monocytes or histiocytes. That's what a CD68 stain tells you. It's of the histiocytic lineage, but those are not neoplastic cells. I don't suspect. The things that you'd be worried about on a bioprosthesis are lymphomas. So DLBCLs associated with chronic inflammation are one of the more common things that arise on prosthetic devices in the heart. So we see them around pacemaker leads. You can see them near IVC filters. So any indwelling intravascular device can develop these PEL-associated tumors that are all primarily EBV driven. And they're responding to kind of chronic inflammation that's incited by that foreign body in there. And so they typically arise around the sewing ring of bioprosthetic valves because that's where most of the inflammatory reaction starts. And then again, an underlying EBV infection that's either happened prior to the bioprosthesis or happens after it, then activates those cells, and you get clonal expansion of the B cells there, and it's a very indolent neoplasm. You want to look carefully for that.
In her workup, we did a pan CT her, also ordered EBV serology, and we just she had no B symptoms, so we less likely thought lymphoma. On the gross resection examination of the suture sites, all the plagets were clean. There wasn't like anything that indicated like a tumor arising from suture lines.
Good. I mean, that's all very positive, I think. I think honestly, what the next step here would be is to repull the primary specimen from this case, and then take a real good look at this second thing and kind of try to put the story together again. I think you gotta look carefully here, because I think you're right. There's more than meets the eye to this case, and what we're seeing here doesn't necessarily comport with the imaging or any of the story. So,
and
let me discuss with Dr. Reardon, and we can maybe send this for a second opinion, further evaluation.
Sure, I'm happy to take a look at it too. Very happy to.
So, Dr. Malazewski, can you comment about the picture from your paper of the myxoma pathology, and then the arrows that are pointing to neoplastic cells? Because I mean, like I said, the typical description of a myxoma is not malignant.
That's exactly right. And so I don't know if we can go back a slide. I think it was one slide ago. Yep, there we go. All right, yeah, so what you're seeing here are myxoma cells, and there's a number of them there. There's a few different types of cells that you're looking at here. The ones that have the black arrowheads pointing to those are the classic lipidic cells, or myxoma cells, and they occur classically in singles or in small multinucleated strands, and that's what you're seeing kind of on the left and the right arrows there. And then the center arrow shows more of a small clustering of these things. Another thing that they'll do is they'll tend to form these little strands that ring up around small blood vessels. And if you look toward the top of that photomicrograph, you'll see a little kind of pink dot that's surrounded by a bunch of blue cells around it. And those too are myxoma cells. And we call those perivascular ring structures. They're sometimes called vasoformative rings, and those are very, very characteristic of a cardiac myxoma. For whatever reason, these cells like the areas of high oxygen tension around those small capillaries. And so you'll see those lots of times aggregating around these tiny little blood vessels. And these are quite vascular tumors usually as well, which can contribute to the fact that they sometimes experience very rapid apparent growth from an imaging standpoint, because these things are being knocked around and beat around obviously throughout the cardiac cycle, and there's all these tiny little thin-walled vessels everywhere, and sometimes they burst open, and when they burst open they bleed into themselves, and that's kind of what you're seeing down there in the left lower gross panel, are the kind of those areas of red, those intratumoral hemorrhage zones, and those can cause pretty massive and rapid expansion of the process when you get significant bleeding into them. And it's very common. These things almost always bleed into themselves over time. That can lead to some other very characteristic histologic findings that we look for, like hemosiderin and gamma antibodies, where the hemosiderin encrusts the endogenous elastin fibers in these tumors. And all the pink stuff, and then that more loose white stuff that you're seeing back there, that's what's referred to as the myxoid stroma. And it is a little bit different in character than the fibrin we're seeing in the index case shown on the next slide. It's a little bit more amphiphilic, it's a little bit more fluffy, less dense. I imagine to many people on the call, if you're not used to looking at slides, you'd say it just looks pink. but there are some subtle differences that we see under the microscope that help us, figure out whether that's fibrin or genuinely a myxoid stroma. And that myxoid stroma is myxoid because it contains tons and tons of mucopolysaccharides, high hyaluronic acid, all kinds of things that are thought to be elaborated by those myxoma cells themselves. Where do the myxoma cells come from? Well, nobody really knows. There was actually a pretty nice study just about a month or two ago. I think it may have been an EHJ or somewhere that talked about just some further evidence that kind of suggests, like we've always thought, that these things arise from primitive multipotential mesenchymal cells in the heart, or kind of these stem cells that reside in the heart that may have a role in very slowly replenishing myocytes, or replenishing and building fibroblasts that then kind of go into the myocardial interstitium and help maintain normal homeostasis of the myocardium. And for whatever reason, obviously in the Carney complex, so the issue is that you get a double hit of the 1-alpha regulatory subunit of the protein kinase A, and that results in unchecked cell growth and the proliferation of these myxoma cells. And we've also seen some evidence to show that you can get sporadic biallelic loss outside of Carney complex. So clearly that 1-alpha regulatory subunit of protein kinase A, or PRKAR1A, plays a role in both the syndromic and non-syndromic varieties of cardiac myxomas. But we only think it explains about a third to half of the non-syndromic. So there's other genes at play there that we're kind of really trying to root out and ferret out. And I think there's a couple of things, some of the phosphodiesterases, for instance, that we think probably play a role. And so I'd expect to see some more data on that in the next year or two, because there's a few groups around the world who are working on that, including us here. And so I think the phosphodiesterases are kind of the next genes we're going to be digging into on this tumor.
Thank you so
Awesome.
much. Yeah.
The one other thing I would just quickly point out, sorry, I don't want to hijack your
No, go ahead.
your really nice review here, but when you were talking about papillary fibroelastomas before, there's been kind of some late-breaking news on those over the course of the last few months, and we've had a paper on this as well. Papillary fibroelastomas are now, we believe, probably
common, right?
And they're definitely more common. That I think is becoming more and more well established.
An epidemiologic paper published in AHA 2020 looking at SEER cancer statistic analysis of pediatric cardiac tumors, I think found a higher incidence of papillary fibroelastoma than previously thought.
Yeah, and Taman also a few years back, I think that was in 2017, maybe 2018, Taman et al. also reported a higher incidence. And so I think, higher resolution imaging modalities have kind of uncovered the fact that these are way more common than previously believed. And certainly even, in my practice, they're substantially more common, both on the surgical side and in the autopsy side, as well as in the consult practice. They're just more common. You see them more commonly across your desk than the myxomas. But they're neoplastic as well. And they likely, at least a subset, we think 50 to 70%, somewhere in there, are the result of mutations in KRAS. And KRAS is, of course, an oncogenic gene. It's an oncogenic driver. It usually plays a role in colon cancer. That's where we usually see it, but it appears to also play a role in papillary fibrolastomas. And so I think there's more to come on that, more to learn on that. But those are now regarded as neoplasms. And we're talking about the 2015 WHO, but the WHO just met a few months ago. I chair the WHO classification thing, and so the new classification should be out in November. And so the 2020 classification is coming out and will reflect all of that information too. So there you have it.
Wow, looking forward to it. That's going to be much awaited for everyone here. So I'll just go through these pretty. I'll like more focus on more the more in-depth cases. Lipomatous hypertrophy of the atrial septum, as you know, is an anatomic variation that is common in the general population, of the incidence of 1 to 8%. It refers to the abnormal, large, generally greater than 1.5 centimeter collection of fat within the atrial septum. It's a non-specific anatomic variant, but has different appearance in cardiac lipoma, which is as you can see, it's a usually well circumscribed lesion, as you can see here, involving adipocytes. And the cardiac MRI with a T1 fat suppression, you can then see this tumor, very clear homogeneous signal in the high right atrium. Hemangiomas, these are benign vascular tumors of the heart. They typically affect any age group and are quite rare. We've seen at our institution, we see more than general practice, but they are usually pretty rare. They can develop a interesting syndrome called Kasabach-Merritt, which involves recurrent thrombocytopenias and consumptive coagulopathy. So anyone with this interesting syndrome, one must think of the cardiac hemangioma. CMR and CT are very useful for delineating these lesions. They are usually, you'll see on imaging sequences, diffuse smooth lobular contours, thin internal septa with T2 hyperintensity on CMR, water attenuation non-CT, and you'll see this peripheral enhancement pattern. The iso intensity and iso attenuation to the blood pool is seen on delayed imaging as well. So to differentiate hemangiomas from lymphangiomas, which are tumors of the lymphatic channels and have very similar appearances, is to look at enhancement differentially with contrast agents. So so the lymphatic component does not enhance as well with contrast agents, and that's the main way you can differentiate with imaging. Rhabdomyoma, a common tumor of the pediatric population. It has its own significant characteristics, including echocardiogram. You'll often see an association with the disease tuberous sclerosis, a genetic disorder associated with seizures, autism. The echocardiogram images will show here, you'll see 3 discrete masses on the echocardiogram, and then you'll see the MRI showing post-contrast inversion recovery delayed, recovery spoiled gradients, and incidentally smooth marginated right ventricular rhabdomyoma. And here's the gross path showing this well-demarcated tumor. And the histopathology, the photomicrograph, showing these legional spider cells of the cardiac rhabdomyoma. And there you go. Cardiac fibroma. So these are interesting tumors of very fibrous tissue, often ventricular involvement, and are often detected incidentally. Very slow growing indolent tumors. They're known to be associated with Gorlin syndrome, also known as nevoid basal cell carcinoma syndrome, an autosomal dominant disorder associated with nevi, as well as ovarian fibromas, intracranial dural calcifications, multiple basal cell carcinomas, and early diagnosis is often beneficial in terms of monitoring. Not all these patients need like AICD or resection for management. They can often be monitored for a while. However, they are at risk of sudden cardiac arrest if there is invasion of the infiltration of the conduction system. So anatomic localization of these tumors is very important, as well as close follow-up. We had an interesting case at our institution of a woman who her mother had Gorlin syndrome, and she did as well, inherited from her mother. And you could see the intracranial, intradural calcifications on head CT, the odontogenic keratocysts of the tumor as well in the mandibular area and the teeth area here. And then here you can see, again, the histopathology, odontogenic cyst showing lesion line by keratinizing squamous epithelium within a fibrotic background. So she initially presented with just nausea and vomiting, vague abdominal symptoms. And it was like the CT scan you see here in D that detected this initial mass here within the left ventricular apex. And this mass was further characterized with cardiac MRI showing a likely fibrotic tumor with a tissue that's iso-intense to the surrounding myocardium on T1 sequence and hypo-intense on T2. So we monitored this patient over a period of 5 years, and you can see the different sequences of cardiac MRI, and you'll see that this tumor was very indolent, literally staying the same mass volume over the past 5 years. We had offered the patient tumor resection, or because she didn't really meet criteria for AICD, and that she had no abnormal dysrhythmia on continuous cardiac monitoring and home monitoring, and did not have any indications for AICD implantation. And we offered surgery, as in that this tumor can at any moment, infiltrate the ventricular conduction system and lead to serious ventricular arrhythmia. However, she did not want to have a significant surgery and opted for watchful observation. And we did this for 5 years, and she still has not had any events. The tumor has literally stayed essentially almost similar in size over the past 5 years. So undifferentiated high-grade sarcomas, these are very aggressive tumors. They denote a poor prognosis. They tend to occur in the right atrium at the atrioventricular groove, and are often presenting with a pericardial tamponade. They are much more diverse in histopathology, and are usually denote a poor prognosis. What you'll see on histopathology is nuclear pleomorphism, and really the immunohistochemistry. You can feel free to correct me if I'm wrong, if there's updates, Dr. Malazewski, but they're usually not as helpful in these tumors.
You said immunohistochemistry is not helpful?
Not as helpful in the undifferentiated high-grade sarcoma.
It's only helpful in the sense that it usually they don't exhibit a lineage specific, they don't exhibit reactivity with a lineage specific marker. And so you can do a bunch of immunostains on it to make sure that it's not something else, but then when they're all negative, it's kind of a more of exclusionary than anything else. You're
So
exactly
Dr.
right.
Maliszewski, how in the world did you get this picture?
I cut the heart.
Right, but you had an MRI, and then you have, you know, your last picture. So that seems rather extraordinary.
Yeah, so we go through great pains here at Mayo. We have a long history dating back through Jesse Edwards, one of the founding fathers of cardiac pathology, of really taking our gross photography very seriously.
A few people getting back on, but it's very disappointing.
Yeah, so I mean, to have him on is pretty amazing.
I know. Maybe he'll jump back on here. Yeah, he's back
Yeah,
on.
he's back on.
I'm here.
Hey, sorry about that. I don't know what happened. I was sort of waiting for what you had to say. So
yeah, I have a flair for the dramatic.
yeah.
I'm not sure how you did that.
So we perfusion fix most of our hearts here that have significant cardiac disease, or if we're suspecting a cardiac death. And we perfusion fix them overnight, so they kind of present themselves to us in a nice end diastolic configuration. And then we try to do our sections that'll marry it up with the best imaging. So in this particular instance, I did a long axis so that we could marry it up. Actually, we didn't include it in the manuscript here because this was for some. I originally had cut it with something else in mind. But the echocardiography on this was actually quite good as well, and the parasternal long axes were fantastic, and so we wanted to marry that up with this, and so that's what that image was there, is the three-chambered view that you were seeing there.
That's
all
like
of our cuts are always
most incredible image I could imagine. It's like, how in the world do you do that? And I would say probably only at Mayo Clinic can you do that. So
yeah, we have approximately 8,000 hearts here that are all cut like that in very beautiful plexiglass containers that are held up with fishing lines and everything. And that teaching set, whenever we have somebody come here, you know, we share it with them. And one of the things we're working on right now is we're 3D scanning a lot of those and then printing them. And then when I go off and give talks or give seminars, I bring a whole cadre of these 3D printed organs and these 3D printed models with me that are essentially exactly what you're seeing there, but they're photorealistic color, and you know, they're made of resin. They're printed on over in our core, our 3D printing core here, and they're fantastic. Those are all kinds of fun to hold because you can turn them around, you can look at them, you can get oriented. They're so much more interactive than just the still frame photos that you see.
wow, that is really extraordinary. Thank you so much for doing that.
There, we got your picture back up. Yeah, we can see that picture again.
Yeah, that's extraordinary, no doubt.
Yeah, it's a labor of love.
Well, we benefit from it. Thank you.
Kalyan, I don't know if you want to make any closing remarks. We're about at the hour. I apologize for the hiccup there.
It looks like he's on, but I don't know if somehow he got kicked off the mic part.
Okay.
Well, I'll tell you guys, I've got to jump off onto another meeting here, but anytime you guys want to talk about pathology or cardio-oncology, feel free to send me a note. I'm always happy to join in.
Oh, that's fantastic. We are so happy that you joined, and this is a beautiful article that we were reviewing, and
you're very kind.
Appreciate it.
You're very welcome. Thank you, guys. Have a good day.
All right,
Stay safe.
Thank you.
Great job, Cal.
Thanks. I'll just, I guess, close with the summary. It's a really amazing article. I recommend everyone to spend some time with it. It's been a reference for the most part, and I'm looking forward to Dr. Melzewski's new contributions in the revised guidelines coming in November, and I assume another amazing paper to come out as well. I'll just review the post-test questions. Which of the following malignancies most commonly metastasize to the heart? Is the renal cell carcinoma? Which of the following most commonly occurs in the right atrium and likely to present pericardial tamponade? That is the angiosarcoma. Typically localizes to right atrium, involves hematogenous spread. These are blood vessel-rich tumors, and it can lead to catastrophic hemorrhage with cardiac tamponade. Where we are a center with a lot of surgical experience in resection of primary cardiac angiosarcomas, the pioneering of the autotransplantation technique by Dr. Reardon has occurred at our institution, and he gets many referrals for this tumor. Unfortunately, advances in systemic therapy have not caught up at all. And the next question is, the primary cardiac tumor most often located in left atrium, low attenuation on CT, and T2 hyperintensity is the myxoma. And question number 4, primary cardiac tumor usually appears hyperechoic on echocardiography, hypointense on T1, and the homogeneous delayed late gadolinium enhancement on cardiac MRI is the fibroma. And I would like to thank everyone for joining me in this conversation, especially Dr. Melzewski and his insight into primary metastatic cardiac neoplasia. And you can please feel free to follow me at Twitter, or feel free to send me questions at the included addresses there. And if you want to get CME credit for this, please use the EDS code for this webinar to evaluate the program. Thank you, everyone, and
Super.
Awesome conversation.
Yeah, great job, Cal. Thank you so much for all of that. Really wonderful.
Thanks, Cal.
Yeah, thank you, Cal. Thanks, everybody, for joining today.
Yeah, awesome job, Cal. Great discussion.
Thanks.
Hopefully see you all next week, same time for a case review webinar.
Sounds good.